All right, so we're going to talk about cardiomyopathies. Effectively, when you're thinking about what is cardiomyopathy, when you think myo, you always want to think muscle. Um, and this is a disease process affecting the heart muscle, which, again, so sad that the heart ever has to be affected. Um, a lot of people get this mixed up with heart failure because it looks a lot like heart failure because it is a failure of the muscle or the pump in some way, shape, or form. There's three types of cardiomyopathy. There's dilated, hypertrophic, and restrictive. So when you think dilated, think thin walls. And when you think hypertrophic, think thick walls or in a thick septum, which is that muscle that's in between the right ventricle and the left ventricle. And then when you think restrictive, think stiff walls. And I was trying to earlier when I was making this PowerPoint come up with a like an analogy, kind of like um, the three little pigs, and they each had a different house made of different things. And I almost got it working because kind of like. Dilated is the house made of straw, and hypertrophic is like the brick house. But it doesn't really work for the story because that brick house actually does stand the test of time, and the wolf isn't able to blow it down. So, needless to say, I almost had like a really cool analogy or story for cardiomyopathy. So, when you're looking at dilated cardiomyopathy, we'll start with that one. Like I mentioned, this is where the walls are thin and weak. This is the most common type. So, remember again, we're talking about a disease process of the heart that's a problem of the heart muscle. And so, what happens to the heart muscle, and a lot of these cardiomyopathies, when we talk about them, I'm not sitting here talking about the cause. There's a lot of different causes things that can cause them, whether it's heart attacks or a lot of times it's just genetics, and there's not a lot that's well understood about why sometimes these happen. But anyway, no matter what eventually happens is that the wall of your left ventricle, which that's your powerhouse, that's what's pumping blood out to the rest of your body, it gets thin and weak. And so, at first this might seem like it's good because it's thin, there's more space for blood to get in there. But here's the thing, it's thin and weak. So it's thin and it has no strength to actually push blood out to the rest of the body. And so, since there's no strength, there's lots of blood pooling, which of course we talk about later. We're going to be worried about clots. Anytime blood is pooling especially in the heart, where does it have to go? Blood pools, clots form, and what happens? Where does the blood go after the left ventricle? To the rest of the body. And then, of course, because this patient is not getting blood out, blood can't be pushed forward because they have thin, weak walls. There's poor cardiac output. So the patient's not oxygenating well. They're usually not breathing well. They can have signs of heart failure, fatigue, and can't breathe, is usually some of the biggest complaints that they're going to have. The treatment is, of course, we want to decrease the workload. Anytime the heart is working super hard or on overdrive, we always want to do things what we can to try to help to counteract how the body tries to help. So this is going to maybe not make sense at first, but effectively, when you think about how your heart compensates, like if you got up right now and you ran around in a circle, or maybe you're watching this and you're getting incredibly stressed out and saying, "Oh my gosh, I don't know anything about this." So your heart rate's starting to increase. You are compensating for something. And that's what your body always tries to do because your heart's so incredibly smart. So if my heart's not pumping blood out well for whatever reason, my body's like, it's okay, don't worry. I'm going to stimulate my sympathetic nervous system. I'm going to stimulate that. And what that's going to do is it's going to increase my heart rate and increase my contractility or my squeeze. And that helps so long, or, it's only so much. But if I'm already not having good cardiac output and my heart muscle's already really weak, if I'm overworking it because I'm pumping really fast, like my heart rate's increased, that can make problems even worse. And so I'm going to use medications like beta blockers to kind of slow down that process where my body's trying to help, but it actually just makes things worse. I'm also going to use things like ACE inhibitors or ARBs. And what those do is they block the renin-angiotensin aldosterone system. I already told you you have blood pooling in your left ventricle. So you already have too much fluid on board. And so what ACE inhibitors are going to do, are they're going to help so that they're going to block, pretty much that the renin-angiotensin aldosterone system, which, primary job is to hold on to more sodium and more water. And how that works is effectively the kidneys are really selfish organ. I'll have another video about how selfish the kidneys are and how they always want blood flow. But what happens is when they don't get their blood flow, they start to pretty much stomp their feet and say, "Oh, no, 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 I'm not putting up with this." And so they secrete, or kind of start this cascade called the renin-angiotensin-aldosterone system. I'm sure you've heard of it and cried over it at some point in nursing school. But effectively what that does is that, kind of it constricts your arteries, which obviously we don't want in a case like this, because if a patient's already working so hard to get blood out, we don't want to have really tiny vessels where we have to fight against a lot of pressure to get blood out. And then also the renin-angiotensin-aldosterone system, it forces you to hold on to more sodium, therefore hold on to more water. And this is all not good for a patient that's already struggling with their fluid load and struggling to get fluid moving forward. So ACE inhibitors and ARBs can help stop that process of holding on to more sodium and more water. And additionally, we can also use diuretics to, kind of decrease that fluid load of the heart so the heart doesn't have to work so hard. My end goal, of course, is I want adequate cardiac output. Most likely, this patient's going to need a transplant, as once the wall of the heart becomes thin and weak, there's not very much that can be done to help with that or reverse that damage that's done. On the opposite end, there's hypertrophic. So we just talked about a thin, weak wall. Hypertrophic is the opposite. This is a thick wall. And a bigger muscle may seem like a good thing, like, oh, wouldn't a thick muscle be great? It's a lot better than that thin muscle, in the dilated cardiomyopathy. But here's the thing, a bigger muscle does not help in this situation. There's no space to fill. Like, look at this picture here. There's no space in the ventricle to fill with blood. And because there's no space, um, you know, um, that's going to lead to a problem where like no blood can get out because no blood can get into the ventricle. Like there's just no way to have good cardiac output. Hypertrophic cardiomyopathy is also commonly known as athlete's cardiomyopathy. So if you've ever heard of people that are what do you call it? Like athletes, like young kids that are like, have sudden cardiac death, like they're running a marathon or something like that, or they're running track for their like middle or high school and they just pass out, or they die, which is horrible. Like what a lot of times the cause is they have this congenital hypertrophic cardiomyopathy. And effectively, they don't know it because they're an athlete and they think they're in shape. And a lot of times these patients are asymptomatic. But usually, if they're going to have symptoms, it's going to appear during activity. Dysrhythmias can be common as well because anytime that muscle of the ventricle is affected, it gets very irritated very easily. And since like the electrical signals won't get sent as well because there's that extra muscle. But effectively, we want to watch for that as well. But this thick muscle, as much as it may seem like a thick muscle will help, it's not necessarily. It's not what do you call it? It doesn't necessarily mean that it's strong. And even if they still have a good contraction, there's no space. It's all about the fact that there's no space to fill. So how are we going to treat this patient that has this big, thick, and you think of like, if you want to think of it like the athlete's cardiomyopathy, think of it like it's the big, thick, strong muscle, like the athlete's muscle. But even though they have it, there's just no space to get that cardiac output. So what am I going to do? I'm going to, of course, if they have dysrhythmias or they're at risk, I'm going to treat their dysrhythmia and any complications. Like if they're in atrial fibrillation, I'll treat them, with anticoagulation and things like that so that they don't get blood clots. And then if they have any ventricular dysrhythmias, they may be on, medications to help to treat those, each individual dysrhythmia. These patients commonly are going to need an ICD or an implantable cardioverter defibrillator. So in other words, they're going to need a device placed. This is not exactly like a pacemaker. What it does, it's literally kind of like having what do you call it? Why can't I think of the way? Like a crash cart in your body. So it's literally like having one of those when you're why can't I think of the name of it? Those little things like when you're out and the AED, that's it, the AEDs. Like it's having like an AED, but in your body. And so effectively what it does is it's constantly monitoring your heart to see what your rhythm is. And if you go into an abnormal rhythm, it can shock you. And these devices are very scary for the patients, of course, that have them because I mean, it kind of tells you it's about to shock you, and it's no fun to be like, oh my God, I'm about to get shocked. But it's a lot better than death. So, these devices are commonly placed because these patients, even if they haven't yet gone into that rhythm, they're very high risk for going into an abnormal rhythm or for their heart stopping altogether. And so what we do is and again, you can't shock nothing, but they're really commonly going into those ventricular dysrhythmias like VTAC or VFib. And so if that happens, then that implantable defibrillator can actually shock them back to life, hopefully. There is some surgical options for a patient with hypertrophic cardiomyopathy, such as cutting the muscle. And so, the problem here is there's excess muscle, so there's not as much space. So they can sometimes cut the muscle down, and they'll cut the septum. They can ablate it with alcohol, and kind of pretty much try to get rid of so much tissue so that there's more room. And then we're also going to encourage this patient to avoid, as a whole, strenuous activity. So last but not least, there's restrictive cardiomyopathy. And when you're thinking of restrictive cardiomyopathy, think of no stretch and a very stiff wall. So this one, it's not too thick, it's not too thin. The problem is it's stiff. And because it's stiff, it cannot fill the way. Because most of the time, your ventricles, like as they fill, they expand and fill up with fluid, just like anything. Like think of, if you were pouring water into a Ziploc bag and how it would expand as you pour that water in. But these are very, very stiff. They have no stretch. And so as your heart's trying to fill, it can't fill. So it's the same problem, kind of like with hypertrophic, where it can't fill, but it's just a different problem in that it's because the walls are stiff, not because they're thick. It has a lot of secondary causes, so there's some autoimmune and other disorders that are related to this as well, but it's not well understood why this happens. These patients are going to have signs and symptoms of poor cardiac output. So they can't breathe, they can't tolerate activity, and they're also going to have signs of heart failure like fluid overload as well. If they have, a secondary cause, that's causing them to have this stiff walls, then we're going to treat that original cause. If they're having any abnormal heart rhythms, of course, I want to treat the complications from the rhythms too. But if they're having any abnormal heart rhythms, I want to treat those. And I'm going to, again, kind of the same as we've been talking for all of these cardiomyopathies. I'm going to treat the heart failure and then treat the symptoms and try to make their life as comfortable as possible and their symptoms decreased as much as possible. Most likely, this patient's going to need a heart transplant because, again, the problem is stiff walls. And a lot of times, again, we don't even know why it's happening. And if we can't, if there's no secondary cause that we can find and fix, then at the end of the day, this patient has a ventricle that's going to be so stiff, it's never for the rest of their life going to fill the way that they need to get adequate cardiac output. What are my goals for all cardiomyopathies? I want to prevent complications, especially death. I want to improve their quality of life and treat symptoms. I want to work on their activity tolerance, that energy conservation that I've talked about a lot, kind of teaching them to balance activity and rest. And then, of course, adequate cardiac output at the end of the day, making sure that their tissues are getting perfused. I'm going to teach them, really focus on that medication adherence. I want to prevent the worsening of their condition because a lot of these, the only way that it's going to get better is if they get a new heart. And so a lot of these patients long term, they're going to be like on an LVAD, waiting on a transplant. And so preventing them from going into cardiogenic shock or other things by making sure that they're regularly managing their cardiomyopathy is so key. So like all those medications like I talked about that help to prevent the heart failure from getting worse, I really need to make sure that they're taking those every day regardless of whether they're feeling okay or not. I also want to avoid the heart being overstimulated, so I'm going to avoid any sort of stimulants. I also don't want it to be overworked, so I'm going to avoid vigorous activity. A low sodium diet can help to prevent a lot of the fluid accumulation that can commonly happen in patients with cardiomyopathies. I'm going to teach them all those energy conservation techniques so they can have a good quality of life. And their loved ones are probably going to need to learn CPR because a lot of them are going to be at risk for sudden cardiac death. So I want their family to be prepared and know what to do in an emergency situation. All right. Well, that is all I've got for cardiomyopathies. I hope you enjoyed it. See you next time.